Hi folks, welcome to my channel, The Average Dermadoc. Let's begin the show. Corticosteroids. These are the most used as well as most abused drug in our dermatology. Most of them which we use will have more of glucocorticoid effect and less mineralocorticoid effects. Why? Our therapeutic effects all are based on this glucocorticoid effect only. We don't want any mineralocorticoid effect. Why? What is meant by mineralocorticoid effect? It means retention of a tasty mineral, that is salt. If retention of salt occurs, along with that water retention occurs and there will be elevation in our blood pressure. This undesirable effect we don't want. So most of our drugs will be with more of glucocorticoid effect. Coming to its mechanism of action. Corticosteroids can act on all the cells in the body. It acts by two types. One is genomic, name itself telling its action is via genes. That means it has to enter nucleus. It takes time, that is hours to days. Another one is non-genomic, name itself telling us no need of any gene interaction with steroid. It will be acted via membrane bound receptors and it shows immediate effects within seconds to minutes, because there is no need of steroid to enter cytoplasm and then nucleus and then interact with genes. This action is non-genomic. Within seconds to minutes it will act via membrane bound receptors inhibiting histamine, phospholipase A2, which will lead to rapid therapeutic effect, that is rapid reduction in erythema, pruritus and wheals in case if we apply topical corticosteroids. Wherever we apply, there will be rapid reduction in erythema. Once I went to my assistant madam's clinic. There she has performed chemical peel on one patient, for which she got intense diffuse erythema all over the face with burning sensation. I got panicked what to do. Immediately my assistant madam gave her least potent corticosteroid, that is hydrocortisone, just a fingertip unit. She applied all over her face as a thin layer immediately, just in seconds, just like magic. All the erythema all over her face got vanished and her burning sensation also reduced immediately. Why? Because of this non-genomic action of corticosteroid. And whenever we transfuse blood, we will be keeping as an emergency drug, that is injection dexa, systemic corticosteroids, to treat anaphylaxis if at all occurs as an emergency drug. For any emergency drug, they should act within seconds to minutes. Here corticosteroids can act as emergency drug to treat anaphylaxis. Coming to genomic action, first steroids will enter cytoplasm. There it binds with glucocorticoid receptor. All our therapeutic actions are via glucocorticoid effect only. That's why here glucocorticoid receptors it is binding in cytoplasm. Then this steroid and glucocorticoid complex will enter nucleus, where they interact with genes. They have to interact with genes because this is genomic action. After interaction, it will lead to changes in gene expression and protein synthesis, ultimately producing the therapeutic effect. But it takes some time, not like non-genomic. Immediately within seconds, it can't act. Mainly steroids will have anti-inflammatory and immunosuppressive action. How it exhibits this anti-inflammatory action? We'll see. It will inhibit the expression of pro-inflammatory cytokines. What are pro-inflammatory cytokines? TNF alpha, interferon alpha, interleukin 1, 6 and 8. All these pro-inflammatory cytokines expression will be reduced because it inhibits nuclear factor kappa beta activator protein 1, which upregulates the expression of these pro-inflammatory cytokines. Clear? First, it is inhibiting cytokines. No cytokines, no inflammation. Next, it stimulates lipocortin. What is this lipocortin? This lipocortin will inhibit phospholipase A2. Here we have seen already phospholipase A2 is getting inhibited in non-genomic action also. What does phospholipase A2 do? It will convert arachidonic acid to prostaglandins and leukotrienes. So now it is getting inhibited. No prostaglandins, no leukotrienes. They are inflammation mediators. No inflammation. Simple. Phospholipase. P for prostaglandins, L for leukotrienes, A2. A for inhibition of arachidonic acid. Clear? Next, it reduces the number of Langerhans cells. What Langerhans cells will do? They will do antigen presentation. So here it affects antigen presenting function. Next, it inhibits lymphocytes, natural killer cell activity, and antibody mediated cytotoxicity of lymphocytes. Polymorphonuclear leukocytes are also getting inhibited. So there won't be normal phagocytosis and antimicrobial function. It reduces the number of monocytes, leading to affected antifungal action. It inhibits mainly histamine. How? By inhibiting the IgE dependent sensitization of mast cell. If there is no sensitization by IgE, no mediator release will occur. No histamine will get released, ultimately leading to anti-inflammatory action. Clear? Inhibition of cytokines, inhibition of phospholipase A2, prostaglandins, leukotrienes. All other cells like mast cells, monocytes, Langerhans cells, lymphocytes, polymorphonuclear leukocytes. Everything is inhibited, ultimately anti-inflammatory action. Next, immunosuppressive action is via inhibiting nuclear factor of activated T cells. To inhibit inflammation, it has inhibited nuclear factor kappa beta. For immunity, it is inhibiting nuclear factor of activated T cells, which reduces interleukin 2. T for 2, T for T cells. Number of T cells will get reduced, and already present T cells will be stimulated towards apoptosis, ultimately reducing mainly the cell-mediated immunity. That's why I have put here star mark. Mainly cell-mediated immunity will be reduced. Along with that, humoral immunity also will get affected. Antiproliferative action. It is seen mainly with topical and intralesional corticosteroids, where they will inhibit mitosis of keratinocytes, which leads to epidermal thinning. And it also inhibits mitosis of fibroblasts. In dermis, without fibroblasts, no collagen will be formed, no glycosaminoglycans will be formed. It will lead to dermal atrophy. If dermis got atrophied, it will lead to striae. This striae is irreversible. Then it will form telangiectasia. If dermis got atrophied, blood vessels will be easily visible through the thin epidermis. That is nothing but telangiectasia. Then there won't be any support to blood vessels. Collagen is not there, glycosaminoglycans is not there. Blood vessel will get dilated and leaky, which leads to purpura and ecchymosis. Where we have applied steroids at that place, all these will occur because of dermal atrophy and epidermal thinning. Then vasoconstrictive effect. Steroids will inhibit vasodilators like histamine, bradykinin, prostaglandins, and it will also increase vessels sensitivity to catecholamines, which leads to vasoconstrictive effect. Directly on blood vessels, it is doing vasoconstrictive effect. Indirectly, because of dermal atrophy, it will lead to leaky blood vessels and telangiectasia, dilation. Antipruritic. If there is no histamine and no inflammatory mediators, it will obviously show antipruritic action. Melanopenic. Mainly topical corticosteroids will show this action. It inhibits melanocytes from synthesizing melanin. Clear? This mechanism action is same for both topical and systemic corticosteroids. Mainly difference comes here. Antiproliferative effect For systemic corticosteroids, it will be there but will occur very late. But for topical and intralesional steroids, mainly antiproliferative action will occur. Then melanopenic action also is seen mainly with topical steroids. Coming to topical corticosteroids, what is an ideal one? Ideal one should stay long in high concentrations in the skin at the site of application. Wherever we applied, it should stay there in high concentrations in the skin only, resulting in lower absorption rate into systemic circulation. Without getting absorbed into systemic circulation, it should act wherever we applied on the skin only. How we will select a topical corticosteroid? Based on potency of the drug, disease type, site and age of the patient. According to age, skin thickness will vary. Children and old age people will have very thin, fragile skin where absorption of corticosteroids will be more. So we will give them only mild steroids. Same, according to site, we will decide which corticosteroid should we prescribe. For example, most potent ones we will give over thick skins, that is over palms and soles. Why palms and soles are thick? Because of an extra layer, stratum lucidum, and over lichenified and hypertrophic diseases. If our skin got lichenified, it will become very thick. Then we have to give potent topical corticosteroid only. Where we will prescribe least potent? Over thin skin. Where we can observe thin skin? Over face, particularly around the eyes. Eyelids will be very thin. Intertriginous areas and over genitalia, mainly scrotum will be very thin. Those areas we will give least potent topicals. Ointments are more potent, then followed by creams, followed by gels, lotions and solutions. Why is this potency varying? Because of oil content. If oil content is more, it will be staying more, forming an occlusive barrier and will have more potency. Remember, O for ointment, O for oil, more oil content. Topical steroids are classified based on their vasoconstrictive effect into 7 classes. We will see one by one. For easy remembrance of this classification, we have to remember ointment is more potent. Gels, lotions, solutions are least potent. Coming to class 1, super potent steroids. What are they? Clobetasol propionate, halobetasol propionate, betamethasone dipropionate. All are 0.05% ointments or creams. What we have learned, ointments are more potent. Here in super potent class, all are ointments or creams. Remember like this. Halobetasol, halo for halo man, beta for 2, di for 2, betamethasone dipropionate, 2 plus 2, 4. Remember like this, fantastic 4. Halo man along with fantastic 4 roaming around the globe. Here globe means globe, clobetasol. Why I am telling like a story? It is very important to know what are super potent and what are least potent corticosteroids. Now we will see least potent corticosteroid. Class 7, that is hydrocortisone. What we have learned, if oil content is more, it will be more potent. Same, if water content is more, it will be least potent. Hydro means water. Hydrocortisone, least potent. Clear? Most potent, class 1. Haloman along with fantastic 4, that is beta 2 dipropionate, betamethasone dipropionate roaming around the globe, that is clobetasol. Super potent, class 1. Least potent, class 7, that is water, hydrocortisone, just hydrocortisone or hydrocortisone acetate. Next, class 2 potent. Remember class 2 for 2 drugs, mometasone, mometasone, class 2. Triamcinolone, T for triamcinolone, T for 2, class 2. Both are ointments. Potent, mometasone, triamcinolone. Same these two, if we change formulation to cream, potency, class will change to class 3. See, mometasone, furoate, cream. Triamcinolone acetonide, cream. Class 2, 2 drugs, momate, triamcinolone. Ointments. If we change it to cream, it falls under class 3, simple. These two finished. In addition, it will have betamethasone valerate. Beta for 2, V for 1. Remember like this, 1. 2 plus 1, 3. Class 3, betamethasone valerate. Next, fluticasone propionate. Class 4, mid-strength. Again, 2 drugs we have to remember. That is hydrocortisone valerate, hydrocortisone butyrate. If only hydrocortisone is there, it falls under least potent. If we add anything like valerate, butyrate, it will fall under mid-strength if it is ointment. If we change formulation to cream, they will fall under next class. Class 5, mid-strength, hydrocortisone valerate cream, hydrocortisone butyrate creams. If it is just hydrocortisone or hydrocortisone acetate, it falls under least potent. Next, along with that, betamethasone valerate cream. Here, from ointment to it changed to cream. Then betamethasone dipropionate lotion. What we have learned, ointment is most potent, gels, lotions, solutions are least. So here, betamethasone dipropionate, our fantastic 4, most potent one because of ointment and cream. If we change that formulation to lotion, it is falling under class 5. After fantastic 4, now 5. Betamethasone dipropionate lotion. If it is ointment or cream, super potent. Then mild steroids. It is very important to know what are mild steroids. To prescribe for children's, old age, or face, genitalia, intertriginous areas, or thin skin, we have to prescribe mild and least potent ones only. What are those mild steroids? Desonide, triamcinolone acetonide, lotion or solution. Lotions, solutions, gels falls under least potent. Now triamcinolone acetonide, T for 2, I told in class 2 because it is ointment. Now gel, solutions, lotions falls under mild steroid class. Class 6, betamethasone valerate lotion. Lotion least potent. Mild. Fluocinolone acetonide, cream or solution, 0.01%. All these are mild steroids which you should have in your fingertips. You should have in your fingertips super potent, least potent, then mild steroids. Clear classification? Coming to indications. For each and every disease, most of the diseases we will be prescribing topical corticosteroids. Coming to eczematous diseases, nummular eczema, steatotic eczema, dyshydrotic eczema, that is also known as pamphylix, diaper dermatitis, piderus dermatitis. This piderus dermatitis is because of the insect beetle, not because of beetle bite. Because of us who crushes that beetle when it is irritating our skin. Because of this crushing effect, that beetle will release toxin called piderin. Because of that piderin toxin, it got its name piderus dermatitis. After crushing, that toxin will cause dermatitis. If we fold our hand, another skin will come into contact with this toxin and may lead to kissing lesions, which we can see in piderus dermatitis, for which we will give topical corticosteroids. Contact dermatitis, chronic actinic dermatitis, seborrheic dermatitis, lichen simplex chronicus, atopic dermatitis. Next, papulosquamous diseases like psoriasis, pityriasis, rosea, lichen planus, lichen nitidus, erythroderma. Pigmentary diseases like vitiligo, melasma. For melasma, I have told in retinoids class, Kligman's formula and modified Kligman's formula, where we will have retinoid, steroid, and one depigmenting agent hydroquinone. Next, bullous diseases. Bullous pemphigoid, cicatricial pemphigoid, pemphigoid gestationis, foliaceous, vulgaris, neutrophilic dermatosis like Sweets, Behcet's, Pyoderma, gangrenosum, connective tissue diseases like Morphea, subacute cutaneous early dermatomyositis, cutaneous malignancies like T-cell lymphoma, lymphocytoma cutis, lymphomatoid papulosis, mucous membrane diseases like aphthous stomatitis, geographic tongue. This geographic tongue is absolutely benign. 1 to 3% of normal population will have this geographic tongue. No need to worry, no need of any treatment. It will be mostly asymptomatic. Pruritus, ani, vulvae, June's balanitis. Others like alopecia areata, acne chilidalis nucae, lichen sclerosis, et atropicans, granuloma annular, papular urticaria, PUP. PUP means pruritic, urticarial, papules and plaques of pregnancy. Prurigo nodularis, scabies nodules, pre-tibial myxedema, scleromyxedema, necrobiosis lipoidica diabeticorum, Jessner's lymphocytic infiltrate. Very long list. It is easy to remember where we won't prescribe steroids. Coming to adverse effects. As we already know, because of dermal atrophy, striae atrophy will come. Striae is irreversible. Acne form eruptions. Rosacea like rashes. In acne, we have different forms, like 4 grades of lesions, but here in steroid induced acne we have only one grade, that is monomorphic papules. Allergy to vehicles. Hypopigmentation, which is also reversible. That means if we stop the drug, this hypopigmentation also will revert back. So it is not permanent hypopigmentation. Hypertrichosis, mainly we can appreciate in women and children, which is also reversible. It will come back. These steroids will act like androgens and stimulates vellus hair to convert to terminal hair, which will be easily appreciable in women and children. What about men? Men will already have more of terminal hair all over the body. We can't appreciate much. Infections like parasitic, scabies, viral, molluscum contagiosum, herpes. Because of immunosuppression, herpes may get reactivated. Fungal infections like dermatophytosis, Tinea incognito. Incognito mode means invisible. Fungus will be classically annular, will lead to classical lesion like annular peripheral raised edges. But with the steroids, there will be inhibition of inflammation, but fungus will be growing happily inside. We can't appreciate normal lesion. It will be like modified lesion. That's why it is called Tinea incognito. Hidden fungus behind these steroids. Candida and versicolor. Tachyphylaxis. What is meant by this tachyphylaxis? Repeated application of potent topical corticosteroid leads to reduced response despite the same dose. We will prescribe a potent corticosteroid to patient. He will apply. Immediately he will get therapeutic response. Patient will be happy and he will praise you that my disease gone very quick. Then after repeated application of same dosages, response will also get reduced despite application of same dose. This is because of tachyphylaxis. What happens? What is the reason? This is because of desensitization and down regulation of receptors. Number of receptors will get desensitized very fast to potent steroids and they won't respond much for the same dose, and number of receptors also will get down regulated. That means number of receptors will get reduced in response to repeated applications. That's why what we have to do to avoid this tachyphylaxis, potent topical corticosteroids should be used for a short period. Once the disease gets controlled, within 2 weeks, we have to shift the patient to maintenance therapy with low potency steroids. Low potent steroids will also get tachyphylaxis, but not as fast as potent steroids. So, to reduce side effects also, we have to shift the patient to maintenance therapy on less potency steroids. If potency increases, parallelly side effects will also increase. So to avoid that side effects and to avoid tachyphylaxis, we shouldn't prescribe potent topical steroids more than 2 weeks. For the sake of patient happiness, you can prescribe only for short period. Then you have to shift. You can't continue for long. Topical steroid damaged or dependent phases. TSDF. What does this mean? It is semi-permanent or permanent damage to facial skin and psychological dependence. Without applying the drug, patient can't be okay. That is psychological dependence. Why this will happen? Because of irrational, indiscriminate, unsupervised or prolonged use of steroids, resulting in plethora of cutaneous signs and symptoms. Plethora means a large number of cutaneous signs and symptoms. What are those? Papules, pustules, pigmentary changes, perioral dermatitis, atrophy, striae, hirsutism, telangiectasia, miliaria because of blockage of sweat glands, infection, folliculitis, mainly diffuse erythema. It is the hallmark of steroid damaged phase and it is also a marker of flare-ups on withdrawal. Patient will be dependent on steroids. If he stops, flare-ups will occur on withdrawal. This dependency can occur with short-term use of potent topical corticosteroids. Even with short-term usage also it may occur, and long-term use of mild steroids. What are dermoscopic features? Dilated tortuous vessels, white structureless areas. Systemic side effects. Even with topical corticosteroids, systemic side effects can occur. How? Because of prolonged period usage or applying over a large surface area. If you apply steroid all over the skin, ultimately they will get absorbed into systemic circulation and leads to adrenal suppression because of suppressing HPA axis, which will lead to Cushingoid features like moon phases, buffalo hump, Addisonian crisis. We will see this in next class. Growth retardation in children, glaucoma, cataract. Particularly if we apply around the eyes, it will get absorbed and leads to glaucoma, cataract, and it may also lead to vision loss. So we should be very cautious while prescribing steroids on face. Children and elderly should always be prescribed low potent steroids for short duration only. Lactating females should never apply before feeding. Coming to contraindications for any drug, either it may be oral, topical, hypersensitivity is absolute contraindication. Relative contraindication is infections, ulcerated skin. Only one condition where on ulcerated skin also we will apply steroids. We can also give intralesional steroids. What is that condition? I will answer this in my next class. Combination therapy. We will combine steroids with some other topicals like antibiotics to eradicate superadded infection and to counteract superantigens. While applying steroids, there won't be any immunity against staphylococcus. It will grow more. So to counteract that superantigen production, we will give combination of steroids and antibiotics. But the problem is it may obscure diagnosis, develops resistance to antibiotics and sensitizes the patient. For future use, we have to increase the dose of antibiotic or change the antibiotic itself. Steroids plus antifungals combination, where we will use this for severely inflamed dermatophytic infection. To control the inflammation for just a short period only, we can prescribe, but mostly no need to prescribe combination of antifungals. as it may cause persistence of the fungus and aggravation of the disease. Fungus will grow happily under the immunosuppressive and anti-inflammatory effect of steroid. Patient will be absolutely symptom free immediately. He will think he got relieved, but actually fungus will be growing and it will aggravate the disease and it will lead to tinea incognito. Lesions will modify. We can't identify whether it is fungal infection or not. Next, combination with vitamin D3 analogs. In psoriasis, we will give this. Both will have synergistic activity. Steroid activity will be enhanced. Vitamin D3 activity also will get enhanced when we combine both. And individual toxicity risk will reduce. A healthy combination. Topical corticosteroids and keratolytics like salicylic acid, urea. This will cause increased absorption of steroids. Remember the channel name. Don't forget to like, share and subscribe. Thank you. Hasta la vista. До свидания.